And thank you to you for being here with us on this Friday afternoon. I guess physically we are all at different places, but mentally we are sharing this same space here in this lecture. It is a rather novel experience for me. I only had one previous experience doing a lecture through Zoom. It's not a very familiar experience for me, and certainly not what I do usually in my daily work. So it is a rather interesting experience for me. Hopefully, I'm also able to give you back some interesting experience today, talking about cognitive behavioral therapy, which is something that I do in my work at the psychiatric hospital. So in this lecture, I will be introducing to you cognitive behavioral therapy in relatively practical terms, so that you would have a basic idea on what happens during a course of CBT. We will begin by talking about the theoretical model of CBT, also in as much practical terms as possible. We will talk about two commonly used techniques in this therapy, namely cognitive restructuring and behavioral experiments. Lastly, if we have time, we will also go through some of the core principles in doing CBT. That's quite a lot of details, in my opinion, for a 2-hour lecture. What I will try to do is to incorporate 5 minutes break time roughly in the middle of the lecture. So we get a brief toilet break in between the two parts of the lecture. And also at the end, I will try to leave some time to answer any questions that you may have. I'm not very good at multitasking, so it may not be a good idea for me to answer questions as I present on what I've prepared for you. But feel free to pop in your questions in the chat box throughout the lecture. I will try to answer all of them if time allows at the end of the lecture. What this lecture is not, it is not a lecture on the empirical status of CBT. So I will not be going through the data, the studies on the outcome effectiveness of CBT. If you're interested in that aspect of CBT, you would have to read about it elsewhere. And also, today's lecture is not really a clinical training on CBT. If you are interested in pursuing this form of therapy in the future, you will have to pursue more formal and structured training after this lecture. What I will hopefully be able to do is to give you a rough idea on what this school of therapy is about and whether it is a therapy that you would wish to spend time on in the future. So let us begin. I would like to start Okay, all right. So is everybody hearing me well? Because that it was muted earlier. Okay. Can we have a quick indication of whether you are hearing me well? Okay. Let me set. Testing. Testing.試音試音 testing。不如睇一睇啲人有冇講話，聽唔聽到我哋把聲？好。Good now. Oh, good now. Good now. Great. So let us. Okay. Okay, so let's continue. Two simple questions to start with. In your own mind, try to consider these two questions. First of all, when was the last time that you felt upset? It could be sometime today, yesterday, or some time ago. Just recall for a quick moment the last time that you felt upset. And then the second question, what caused you to feel upset? Now, these two questions are not trick questions. They are questions that commonly get asked during a therapy session. In CPT, this school of therapy addresses this issue using the cognitive model. The cognitive model postulates that our emotional experience is influenced by how we process information cognitively. That means how we think. Emotions, whether positive or negative, are the result of our thinking. In other words, it is not a situation in or of itself that determines what a person feels, but rather how the situation is construed by the person. Hundreds of years ago, the English writer William Shakespeare articulated this this idea in the play Hamlet. In Hamlet, he says that there is nothing good or bad, but thinking makes it so. This rather succinct articulation of the idea is basically the foundation of CBT. Mental illnesses such as depression and anxiety are underpinned by systematic biases in how we think about our experience. In CBT, we seek to identify and address these systematic biases with the client. But when the clients learn to evaluate the thinking in a more realistic and adaptive way, they would experience improvements in their feelings. And basically, this idea is what we call the cognitive model. But the cognitive model may not be the natural way in which people relate to their own emotional experience. A more common way in which people usually understand their feelings is that something happened. For example, I feel sad, an emotion, sadness, because I scored poorly in the exam. And scoring poorly in the exam is something that's happened externally, is an external event. Another example, I feel angry because someone jumped the queue in front of me. So here, the feeling of anger is attributed to the event of having somebody jumping the queue in front of me. This idea also applies to positive emotions. For example, I feel excited because I will begin my overseas trip tomorrow. Now, the reason that people tend to talk about feelings in relation to events is that we are usually brought up in such a way. Just imagine a young child going to his mother saying, "Mommy, I feel so unhappy." And what would the mother's natural reaction? Probably something like this. The mother would say, "Oh dear, what happened?" So it is in this way that from a very young age, we learn to associate our own feelings with something that's happened, with some events that's been going on. The problem with this understanding, though, is that events actually have an indirect influence in how we feel. This can be understood if we think about how the same event can lead to different emotions. For example, if we continue using this example, this event of scoring poorly in the exam. For some people, these events can lead to feelings of sadness, very unhappy that the score isn't as good as he anticipated it to be. But for some other people, this same event of scoring poorly in the exam can lead to different feelings. For example, feelings of anger, feeling angry that he scored so poorly in the exam. Yet other people may feel indifferent. It doesn't matter, I score good, I score poorly, it doesn't matter. So why do different people feel differently, even though we are talking about the same event? The reason being that different people have different ways of thinking about the same event. For the person who felt sad for scoring poorly in the exam, maybe the way he thought about this event is that I am bad at doing exams. So scoring poorly in the exam kind of reminded him of how badly he does his exams. This kind of self-defeating way of thinking is causing that feeling of sadness. For the person who felt angry for this same situation, perhaps his thinking would be something like this. The teacher made a mistake. It's not possible. It's no way that I score so poorly. Every time I score so highly for this subject, why this time he gave me such a poor mark? For the person who felt kind of indifferent, maybe the way of thinking would be something like, I didn't like this subject anyway, so it doesn't matter. I don't care. All these different ways of thinking came from the same event. So that is why events have an indirect influence in how we feel. In the cognitive model, these different components of our experiences are differentiated into different categories. So we have the antecedent event, something that's happened, something that's external to us, something that both myself and other people can see and hear. These are concrete events that occur in the world. We also have the components of our beliefs, of our thinking. The parts in blue here. This is internal because it's how we think in our minds. Everybody can think differently depending on how we perceive the situation. And of course, we also have the components at the end there, the consequent emotion. The emotion, the feeling being consequent to how we think about the event. That is why this cognitive model can also be referred to as the ABC model of emotional experience, because it's the A leading to B and leading to C. During the course of therapy, how the clients perceives an event may not be very obvious initially. For a lot of people, the natural tendency is to talk about events and feelings associated with the distress. So identifying the client's cognition requires the therapist's active efforts to probe into it. Let's take a look together into a therapy dialogue. So perhaps this dialogue can, this could very well be something that gets spoken in a therapy session. For example, the client says, "This week has been very bad. I don't know where to start. You know how I'm doing my exams recently, right? It's not going good. I feel so bad. I feel so tired. I know I need to move on, but I just don't have the energy to do so. Every time I try to focus on preparing the next paper, I just get so tired that I have to go back to my bed." So here the client reports to the therapist what's been going on in this past week. There's a lot of description about what's been happening. The events here coded in green. The week has been very bad. I'm doing my exams, it's not going good. These are actual situations, events that's been occurring in the client's life. And then in red, the client describes how he's been feeling bad and feeling tired. And also coded here in purple are the actions that the client has been taking, what he's been trying to do, trying to focus on preparing the next paper, but all he could do was to go back to his bed. Nothing in this dialogue here really talks about his cognition, how he thought about what has been going on. So the therapist has to facilitate this process, finding out the cognition underneath these events and feelings. So this could be something that the therapist says in response. It seems like you're going through a pretty difficult week with your exams going on. You've been feeling bad and unmotivated, maybe a little sad too from what I'm seeing. You mentioned that you do try to work on the next paper, but it's a difficult thing to do because you get so tired. When you were feeling so tired, what was going through your mind? And this last question here in bold is a very key question in CBT. What was going through your mind? Because here we are trying to drill into the cognition. So having asked this question, the client may respond something like this. I just kept thinking how low the test score was and how I'm so bad at doing exams. So finally here, coded in blue, the client mentions very briefly how he perceives the situation, the exam situation, that he believes that he is very bad at doing exams. We have to make efforts into helping out the client in verbalizing the cognition as much as possible, because that would be the target in CBT. We work on the cognition in order to bring about emotional change. So we need to facilitate the clients to verbalize as much as possible what's going through his mind. Let's continue with this dialogue for a moment. The client says that I just kept thinking how low the test score was and how I'm so bad at doing exams. I don't know how I can get through the rest of the exams. I will probably score even worse. Everyone will look down on me. Why can't I do anything well? I don't know how I can tell my mom about this. She will scold me. She always does that. But I know that she's just worried about me since I'm the lowest achiever in the family. My sisters are also capable and independent. I'm just useless. Now, if during the course of therapy, the client is able to verbalize the cognition is in as much detail as the example here, then we know that we are on the right track. We, in fact, based on this dialogue here, can understand quite well how the events has been bothering the client and bringing the emotional upsets that he's been feeling. Now, identifying the thoughts, the cognition, helps us set the stage for developing what we call an individual case conceptualization, also called a case formulation. The formulation can be a rather simplistic and linear model, such as this one here, an event leading to the cognition, leading to the emotion, the ABC model. But we also have to help the client apply this model into their own experience. So we have to fill in the boxes. Like so, the event, scoring poorly in exam, and then the cognition, and then the emotion. So that it's very clear in both the client's and therapist's minds what's been going on, what's underneath, how to explain that sadness. This case formulation is ideally written down together with the client. So the client and the therapist work together and write down this formulation so that they can both share that same understanding of what needs to be worked on in therapy. The formulation can also include a behavioral component. For example, working from this cognition that I am bad at doing exams. One thing that the therapist can ask is, what do you do when you think about this? When you think that you're so bad at doing exams, what tend to happen? What do you tend to do when you think about this? And the client may say something like this. I just get so unmotivated. I feel so tired. I go to bed. I stop working. I stop doing my revision. So basically, is to avoid the very thing that's been causing him the upsetting feelings. But the conceptualization does not end here. We need to explain, we need to work with the client to see how this avoidant behavior, the behavioral component, is in fact reinforcing the dysfunctional thought, because when the client avoid more schoolwork, then inevitably his exam score would be poorer. His academic performance would gradually get worse. And when he sees that his scores are getting poorer and poorer, then naturally he would be thinking even badly about himself and how bad he is at doing schoolwork and exams. So usually it's the case that the behavior reinforces the cognition, and then the cognition feeding back to the behavior and so on. The case conceptualization can also integrate all the different components, namely the cognition, the behavior, and the emotion, in a model like this one. So I'm bad at doing exams, leading to feelings of sadness, and then leading to more avoidant behavior, and so on. They, mutually influence each other. Well, all these three components here are internal to the client, and it's very important to help him understand that these internal processes are different from the external events that occur. Because in CBT, the premise is that we work on internal processes. We work on the cognition, the behavior, and the emotion. We improve these three components in order to help us cope better with the external world. No matter how the case conceptualization is built, the importance is in how to differentiate the components so that the client has a good understanding of what is cognition, what is behavior, what is emotion, and not to confuse it with events. And also to understand how these different components influence each other. The formulation needs to be in a way that is accurate and simplistic enough to be useful for the client. So here's another way of conceptualizing the same issue, starting from the event, scoring poorly in the exam, leading to the thinking, to the feeling, to the behavior, and then back to the events, scoring even poorly next time, and how this event inevitably reinforces the cognition, kind of this vicious cycle that's been really affecting the client and leading to the persistent distress that he may be experiencing. Now in CBT, emotional disorders are understood to be underpinned by negative cognition. Also sometimes we refer that as dysfunctional thought. To address this issue, the client learns to evaluate and respond to negative cognition more adaptively. And one of the ways we do that is through a technique called cognitive restructuring. And in cognitive restructuring, we start by this question here. What makes a thought a good thought? In fact, this is a question that I would sometimes ask of my patients in the hospital. I pose this question to them, and I ask them to kind of think about what would be a common sense answer to this question. Quite commonly, my patients would answer this question by saying, positive thinking. If negative cognition, negative thinking is not good, then perhaps what I need is more positive thinking. Basically, it's just, look at the bright side. And this advice, looking at the bright side, can be a common advice that our clients get from their friends, from their family, when they talk to these people about their distress. These friendly and helpful people when they try to lift up the client's mood, they try to be encouraging. They try to encourage a more optimistic mindset in the client. But while being optimistic can be helpful for some situation, it is often not so helpful for people who experience significant emotional distress. And this would be how they might think about thinking positively. They might think that if I could think more positively, I would have done so already. Or you say I'm not all bad just to make me feel better, just because you're being nice to me. But everyone knows that I'm a failure. A problem with positive thinking is that it may not be a totally accurate reflection of what is actually going on. Just imagine, a very optimistic and positive thinking student thinks that it's okay not to revise for the exam. I will score highly anyway without any studying, without any revision. I will score highly anyway. Now, this may be true or may not be true depending on how clever the student is. But for some people, or dare I say for most people, not revising at all for an exam usually would not lead to a very high score in that exam. So, in fact, this way of thinking is a very positive thought. The very moment he thought about this may be, giving him a lot of positive energy, very happy and very relaxing for the evening. I don't need to revise for the exam tomorrow. But then the problem is it may not be the truth. It may not reflect what is going to happen in the exam tomorrow. So our thinking cannot, just rely on being positive. It has to rely on whether it reflects the reality. In CBT, clients learn to test their own thoughts against evidence. The evidence being, perhaps how things turned out in the past. In essence, they develop an investigative mindset on their thoughts and feelings. And this is facilitated through a process of reviewing evidence. We begin with the subject of investigation, and that would be cognition in terms of CBT, my thought. I need to test my cognition. The cognition, continuing with the same example, would be if I try to do something difficult, then I would fail. The process of investigation would be what's the evidence for and against this thought. And then we start to look at the past and previous experience. What my life experience tell me about this cognition. So the client may very well come up with evidence for this negative thought. For example, he recalls how his mother is always saying to him how he can't do anything well. You always rely on me. You can't do anything well. Your sisters are much more capable and independent. But then, of course, it is usually the case that the client focus on these evidence in support of the negative cognition. And that's why they feel emotionally upset. But then they neglect the other side of the story. They neglect the evidence against this negative cognition. And the therapist has to facilitate the clients to think about that. So it could be, through the process of, reviewing more objectively what's been going on in the client's life. He gradually learns that actually no one else says that. It's just my mom, just my family who thinks that I'm not good at doing anything. And then thinking about past exams, perhaps, I didn't score so bad last time. And the last exam, kind of the difficulty was kind of the same. So it doesn't mean that whenever I try to do something difficult, then I'm bound to fail. And also he could think about, successful experiences elsewhere. For example, a friend telling him that he make very good, very tasty cake. So actually he could do something well. Now, in reviewing the evidence for and against the cognition, the client is guided to kind of hold a more objective view of himself and of what's been going on. We strive for the clients to think in as realistic a way as possible. So the thinking has to reflect the reality as much as possible. But then there's a problem, there's a potentially an issue with this kind of way of thinking. The problem being that sometimes realistic thinking can be the reality can be very cruel. Just think about an example of a otherwise very capable young man ending up feeling depressed after a major road traffic accident where he lost both his legs permanently. If we simply encourage this young man to think realistically about this tragic accident, then, the realistic thinking could be something like, I cannot walk anymore. That's a reality, that's a fact. He will not be able to walk in his life anymore. I cannot work in my job anymore because perhaps his work really relied on him being mobile, moving to different places. And also, I need assistance every time using the toilet. Now, all these things could in fact be true for the rest of his life. And merely focusing on this tragic reality can be very depressing. So what is the conclusion? What do we conclude from this? They start realistic thinking is necessary, of course, because our thoughts, if they do not match with the reality, they deviate from the reality, then to the extreme, that would mean delusion, delusional thinking. So realistic thinking is necessary, but it is not sufficient. We also need our cognition to be useful, to be constructive, to be helpful for us. So this diagram would be, sometimes I write out this diagram for my patients, writing out, how the thinking component is of direct influence to feeling rather than situation. And then underneath the thinking, there are two important pillars, one of which is that our thinking has to be realistic, and secondly, it also has to be constructive, helpful for us. But what happens when our thoughts do not fulfill these two criteria of being realistic and being constructive? Now, it may reflect then that it may reflect a systematic bias in thinking, which tends to lead to emotional distress. Sometimes we say that these systematic biases, we refer them as being cognitive traps. We fall into these cognitive traps, biases in thinking. So let us go through a few common cognitive traps that people tend to fall into. All or none thinking, which is also called black and white thinking or dichotomous thinking. It is a way of thinking about things in absolute terms without consideration of the middle ground. So either the person thinks that if I score well on this paper, then I'm a success. But if I score poorly, then I'm a failure. Either I'm a successful person or am a failure. Very extreme, very dichotomous in thinking, without consideration of the gray area in between. The problem being that in reality, things tend to occur on a continuum. We do need to consider the gray area, not just the extremes. So when we fall into this trap, when we don't think, when we think about things in kind of black and white fashion, then it doesn't fulfill the criteria of being realistic. Overgeneralizing. So this style of thinking is about drawing conclusions for a broad array of events based on a single thing, based on a single event. The problem here is that the person is unable to analyze events independently. Some example cognition and overgeneralizing cognition would be like this. I performed so bad on today's paper, I will surely fail tomorrow's papers. So based on the single events of today, he is already making a judgment about the rest of the events. Or another example, perhaps a person with a phobic response to dogs. He will think like this, this dog bit me. Therefore, all dogs are dangerous. I have to avoid all dogs. So overgeneralizing could be something that, people fall into as a cognitive trap. Catastrophizing, thoughts that the disastrous prediction of an event. This is a typical cognitive distortion for people with anxiety because they tend to exaggerate how bad things will turn out. If I walk near the dog, it will bite me. If I don't wash my hands for 10 minutes, then I will get infected and die. The consequence being a catastrophe. Of course, if we think about events in such a negative way, it may not reflect, again, the reality. Jumping to conclusions, that is reaching a conclusion internally before an event occurs. And it could be in the form of mind reading, assuming how other people think, and also fortune telling, assuming already before an event occurs, what is going to happen. So for example, he's looking towards me. He must be thinking I'm ugly. But then, of course, for a lot of times when people look at us, we cannot be sure what that person is thinking. But some people do tend to jump into conclusions. And then another example, I will place all my money on this bet. I will win this one. Perhaps it's a cognition for the pathological gambler. He's so convinced, he's so sure that his gambling, his bet, will win him a lot of money this time. So he places all his money on this bet. But then again, of course, as with any other gambling activities, he cannot be sure. There's no way that he can be sure what the bet turns out will be. Should and must statements. These are rule-based terms. Thinking about things in should or must ways tend to lead to frustration because it's rather it represents a fixed expectation on how the self, other people, and the world should operate. I must not make any mistake in what I do. He should listen and follow through my instructions. If we, if in our scheme of cognition, we think about these terms on a very regular basis, then the problem is that these expectations may not be met in the real world. Again, it's not reflecting what may happen realistically. And when that happens, when the reality fails our expectation, then we get frustrated. Labeling, assigning negative labels to yourself or other people. For example, I'm a failure or he's a winner. But this way of thinking represents a biased and exaggerated view of what usually is the truth. Emotional reasoning. that is confusing subjective emotions with reality. It's the feeling that something must be true because I feel so strongly about it. For example, I feel so bad. Because I feel so bad, therefore I must be a failure. Or I feel so afraid of him. He must be a bad person. I have this sixth sense that he's a bad person without any concrete evidence of whether this is the case or not. But this is not an exhaustive list of the different types of cognitive distortions. There are also others, and some cognitive distortions are more prominent to specific mental disorders. For example, as we have already mentioned, people with an anxiety problem usually catastrophize what they fear. If we use an example of a person with social anxiety, what they tend to catastrophize is the outcome of social interaction, social situations. For example, public speaking. The cognition of that person may be, if I speak on the stage, I will get so nervous and shaky. Other people will notice how shaky I am and criticize how poor my presentation was. So in this person with social anxiety, he really catastrophizes the outcome of public speaking by imagining that if he has to make that speech, that public speech, that he's going to shake so much and the audience is going to dislike him so much to the extent that the audience would stand up and criticize him. So, in other words, catastrophizing that social situation of public speaking. Another example, patients with schizophrenia, they tend to jump into conclusions regarding other people's intentions. So, for example, a patient with paranoia might think like this, that someone is walking behind me, he must be following me and planning to kidnap me. Really paranoid about what that person behind him is intending to do. So this is about jumping into conclusion, making a conclusion about the other person's intention. But the therapist during CBT can go through each cognitive distortion with the client and then relate this understanding to their own experience. Doing so can help the client gain distance from his own thoughts, therefore facilitating the client to evaluate the thoughts, whether it's realistic enough and whether it's constructive enough. In my own experience, people tend to be surprised when they learn about all these different cognitive distortions. They tend to be surprised at how many of these cognitive traps they fall into. In therapy, they need to build a good awareness of how these cognitive distortions affect their daily lives. So it is not just about during therapy, we identify, the cognitive traps the client fell into on the events that he's been talking about during therapy, but also he needs to apply this understanding to all the different daily experiences he encountered. And one of the ways to do so is by using a tool called dysfunctional thought record. The dysfunctional thought record is usually given to the client as homework in between therapy sessions. So in CBT, the idea of homework is very important. Clients do not get better just by coming to therapy on a weekly basis, to talk about their problems and difficulties for 1 hour each week. But what we rely on is for the client to work on their problems using the CBT method throughout the week. And this could be one of the dysfunctional thought record we give the client early on in the therapy process. We differentiate the different components of our experience as differentiated in the cognitive model. So first of all, in the left-handmost column is the event, what happened. And then in another column, the client has to write down the feeling associated with that event. And then most importantly would be the cognition underlying this event. If the client agrees to use such a record, then we call make a record on a daily basis, then that could be really helpful for him to understand a lot more about his own cognition. Because again, people tend to pay attention to events and to feelings, but less so to their own thoughts. And by using a thought record and writing down the cognition can help this process of bringing out the cognition from the to the conscious mind. There are different versions, even variants of dysfunctional thought record. For example, further on in the therapy process, maybe we will add on different columns to strengthen the client's understanding of the cognitive model and cognitive distortions in this case. So here in the fourth column, the client has to write down which cognitive trap he's fallen into for this cognition here. So obviously that would be after learning about the various different cognitive distortions during the therapy session. And then maybe having learned that for homework would be this form of thought record. This version here trains the client to evaluate his own dysfunctional thought. So what's the evidence for this thought? And what's the evidence against this thought? Here we really harnesses the client's evaluation of helping him to think in more objective mind. In CBT, different layers of cognition contribute to the perception of events. So I guess if you are a student of psychology, you would have seen this image before. In the context of CBT, this image can be applied for the different layers of cognition. First of all, at the surface level, so above water level, what we can see above the surface is the tip of the iceberg. This level of cognition is what we call automatic thoughts. Thoughts, cognition that pop up in our mind in our everyday life. An example of this would be, when the person, receives his exam score is so poor, is so much lower than his expectation, then the thoughts that pop up in his mind could be something like that. I'm bad at doing exams. It's different for everybody. So for the same event, a different person's automatic thought could be, oh, my score is so poor. my mom is going to scold me. I don't know how to explain this to my mom, for example. So it could be different thoughts, different to different people. But beneath this surface level cognition, beneath the water surface, there exists intermediate beliefs. These are in the form of underlying assumptions that influence how we view an event. These underlying assumptions are the if-then statements, the conditional statements that influence how we think about things. For example, in this case here, if I try to do something difficult, then I will fail. These are the rules that govern how we see, how we view different situations. And then finally, at the deepest level, at the very bottom part of the iceberg, are what we call core beliefs. These are in the form of unconditional thoughts. For example, I'm useless. There's no question about that. There's no if or then. I am just useless. And it is an unconditional thought that applies to different situations. In therapy, we help the clients to work through these layers of cognition from the surface level, from automatic thoughts. And then if the clients get some successful experience in changing the automatic thoughts, then we will move on to work on the intermediate beliefs, and then finally to the core beliefs. And that is because it is relatively easier to work on more surface level cognition initially. Usually when we work on the core beliefs of the clients, it would be rather later on in the later part of the therapy process. So we need to help the client restructure their thoughts in a more realistic and helpful way. Just very quickly, we go through these examples. So if the client think about how bad he is at doing exams, then an alternative way of thinking about this would be, I didn't do well this time. So it's not overgeneralizing at all the different exams that he's going to do, but this way of cognition, this way of thinking is specific to this time. If I try to do something difficult, then I will fail. The intermediate belief in the form of the assumption. So we may help the client to think more objectively. For example, if I try to do something difficult, I may or may not succeed. Because the client is not bound to succeed in a difficult situation. He may or may not fail or succeed, depending on that situation. The core belief, I'm useless, the unconditional self-view. We may help the client to see that he has strengths and weaknesses just like anyone else, because that is the reality, that is the truth. Everybody has their own strengths and weaknesses. Now, it's also very important to recognize that CBT does not strive to work on all negative emotions, because the assumption is not that all negative emotions are bad. CBT does not aim to remove all of our distress, because some negative emotions can be normal and in fact adaptive in our lives. For example, when we grieve for the death of a close family member. That person is bound to be, in intense sadness over this event. Now, this intense negative feeling, even though the emotion is negative, does not mean that it's abnormal, does not mean that it needs cognitive restructuring, because grieving is a normal part of life. It helps to give us a sense of closure in a relationship. Another example would be perhaps feeling angry when our rights are being violated, because that feeling of anger gives us the energy and motivation to drive us forward, to defend ourselves so that we do not get continually violated by that same person. So that feeling of anger is, in a way, helpful and adaptive for us. What we need to do is to determine whether that distress is appropriate and in proportional intensity to the event. So now we're just over the 1 hour mark. What I would like to do is to, I would suggest that we take our 5 minutes break here so that everybody, can go to the bathroom if necessary, and just to relax for a few minutes. In the first part of the lecture, I mostly talked about the cognitive model and cognitive restructuring. I will continue in the second part of the lecture to talk about behavioral experiments and also the principles, the core principles of doing CBT. So I'll see you in a few minutes time, in 5 minutes time, starting from now. Okay, welcome back. We will continue with the second part of the lecture. So a brief recap. CBT is based on the cognitive model, which postulates that emotional distress is directly influenced by our thinking. Therapy is based on an individual case conceptualization, which teases apart how different components of our experience influence each other. And cognitive restructuring is a therapy technique that corrects systematic biases in thinking. Now, even though addressing cognitive distortions by ways of cognitive restructuring is an important part of therapy, but there are limitations with the cognitive intervention because sometimes it is insufficient to bring about change. In cognitive restructuring, we often rely on retrospective examination. In other words, what's the past evidence for or against my thought? Looking through the past, looking through past events, what's been happening, what's been going on. We try to use an objective mind to look at the past, but it is still a retrospective way of thinking. But what if the past experience is not informative enough to tell us about the accuracy of the thoughts? So, for example, the person with social anxiety may think that I don't know what will happen when I do public speaking. The audience may or may not criticize me. I have not done it for 20 years. Because this person with social anxiety has been avoiding public speaking for such a long time. He could not remember the last time he's done public speaking. So he really does not know what in fact will happen, whether the audience will praise or criticize him. He just does not know, no matter how he think about it. It may also be the case that the client find it difficult to accept accept or believe in the new alternative thought that we assume is more realistic and more useful for the client. So saying something like, I know the audience will not criticize me. I know that is very unlikely, but I still just can't do it. I just don't feel confident in doing it. I feel so afraid. That is, the issue of knowing the cognition in the head, but not feeling it at heart. So it's not powerful enough to bring about actual behavior change. So other than thinking, we also have to work on behaving. The behavioral interventions are another important part of CBT. There's a variety of behavioral interventions, one of which is called behavioral experiments, which can be defined as a planned experiential activity. Behavioral experiments are commonly used in the treatment of anxiety. Anxiety has two hallmarks. The first hallmark characteristic is apprehension. A person with anxiety has a fear, a very intense fear towards something. The second characteristic would be an avoidance from that fear, running away from the fear, not approaching the fear. Cognitively, clients with an anxiety problem expect a catastrophic outcome when they imagine approaching that fear. For example, in the case of social anxiety disorder, the fear is on social evaluation. Clients with social anxiety catastrophizes the outcome of social interactions. For example, they expect to be criticized or ridiculed when they speak with other people, or when they when they engage in public speaking. The social situations can be just ordinary daily interactions, such as greeting people or in the form of public performance. Social anxiety is not just typical shyness, but it's a really intense fear leading the person to avoid the social interactions at all costs. Now, in terms of behavior, social anxiety is associated with two types of behavior coping. First of all, avoidance. So the person avoids public speaking. For example, in a group presentation, the person with social anxiety may try to leave the speaking part of the speaking part of the group project to his group mates. Trying to speak as little as possible. The other behavioral coping that social anxiety clients engage in is what we call safety behaviors. That means engaging in the feared activity, engaging in the speaking, not really totally avoiding it, but engaging it in a way that he believed would help with the anxiety. But in fact, it really worsens anxiety. Examples of that would be not looking at the audience during the group presentation. So really looking at his notes all the time, looking at the floor, but not directly looking into the eyes of the audience, because he is so afraid, so worried about how the audience is evaluating, is thinking about him. Another form of safety behavior would be to keep checking on himself, really self-focusing his attention on how his body is behaving. For example, some people when they are very nervous, their hands shake, and people with social anxiety may be worried that the audience would see that his hand is really shaking a lot and then think negatively about him. So he wants to check on his own hand and, in order to make sure that if his hand is shaking, then he could hide his hand or, hold on to his shaking hand. In a behavioral experiment, what this client with social anxiety could do is to try to do the public speech and without the avoidant behavior, without the safety behaviors, and to observe the audience reaction, to observe what in fact happens. Guiding the client through the behavioral experiment can help to examine whether his catastrophic expectation of that situation is a realistic appraisal of that situation. The findings of this behavioral experiment would serve as new evidence for the client to evaluate his catastrophic cognition. So the behavioral intervention is really complementary to the cognitive intervention. So in cognitive intervention, we identify the negative cognition. And then in behavioral intervention, we test whether that negative cognition is realistic or not. So first of all, in a behavioral experiment, we have to start off with the cognitive model. We first have to identify the client's cognition underlying the fear. The therapist could do that by asking, what do you imagine will happen when you are speaking on the stage? What do you imagine, in your mind, in your head? What do you fear will happen? And then the client may say that, I will feel very anxious. So in the emotional component, we note down very anxious being the subjective emotion. And then the client may continue to say that, I will get so nervous, my body will shake so heavily. The audience will see how stupid I am and criticize me for wasting their time. And that is the catastrophic expectation for this client with social anxiety. Next, we have to identify the behavioral component of the problem. So in order to do that, the therapist might ask, what do you do to prevent this terrible outcome from happening? The terrible outcome being the audience criticizing him. So the client may then think about, what he usually do in order to avoid this situation, this very bad situation of the audience criticizing him from happening. For example, the client would avoid eye contact and then keep checking his hand. These are the safety behaviors of this example here. So again, we note these down so that we have a comprehensive cognitive model or case conceptualization of this problem. So in running the behavioral experiment, first of all, we have to prepare. We have to find and establish the subjects of the investigation. We have to form predictions or hypotheses of what is going to happen. We have to establish what to do in the experiment, the methodology of the, the experiment. And then there are also the stages of the results, noting down what actually happened, and then the conclusion. So running a behavioral experiment is rather similar to any other scientific experiments. The stages, the processes are very similar. Continuing with the same example of the social anxiety client, so the subject of investigation would be the cognition. I get so nervous, my body will shake, the audience will see how stupid I am and criticize me, and so on. That is, what we have to investigate, whether this thought is accurate or not. Next, the client's prediction. The client, of course, would be predicting something bad that's going to happen, because it is this expectation, this prediction that's been driving his social anxiety all this time. So we can note down something like that, the audience will come forward and criticize me. These ideally would have to be the client's own words instead of the therapist's words. So the therapist merely guide the client to verbalize all these things. The next stage would be establishing what to do, in the experiment. So the experiments could be, simply not to avoid the oral presentation, don't focus on himself, remember to make eye contact with the audience, otherwise he would not know how the audience would respond to his oral presentation. Now we need to do as much as possible to reduce the safety behaviors and to gather new information. Now, the results that will be after doing the behavioral experiments, we have to note down what actually happened. So we asked the client, what happened? Were you successful in doing the behavioral experiment? What was it like? And so on. And so often to the client's surprise, the prediction does not come true. He may have this new experience of finding out that, in fact, the audience did not respond in any special way, not in any negative way. Simply, no one commented how I did. They were okay, they seemed fine with my presentation. Even a few people clapped at the end and gave me encouragement. And then the therapist guide the client to learn from the experience, to draw a conclusion from this new experience. Essentially, it's about coming up with a new, more realistic and more useful cognition. For example, my performance is not as bad as I feel it to be. This final part here of drawing the conclusion of the behavioral experiments is one of the most important parts in this intervention. The therapist has to help to unpack this new experience by asking for a lot of details. So what was the audience like? What was going through your mind as you were doing the oral presentation? How was it different from your previous experience, and so on? So we enrich the details, we enrich this experience, because this behavioral experiment is something that is very new for the client. He will need the therapist to guide him to understand a bit more about, what really happened and what does this mean for how he cope in this situation. When clients are able to go through with the behavioral experiment, we have to attribute this success to the client. We have to celebrate the success together Some clients, they find it difficult to attribute success to themselves, perhaps due to an unresolved negative view of themselves. They may attribute any therapy success to the therapist, but of course, all the successful experience should be attributed to the client. It is he himself who worked hard in making the positive change. So we need to strengthen and consolidate and to celebrate any positive change in therapy. Now, doing behavioral interventions require the client's persistent efforts. They have to really work hard in it. It's not an easy thing for them to do at all. And it is rare for people to recover from emotional difficulties, for example, from anxiety, after just a single behavioral experiment. Even though the cognition may have in some way been decatastrophized after the behavioral experiment, the client would need to gather, to accumulate more successful experience in order to have any persistent positive change in their lives. And in graded exposure exercise, we can do that, especially in the treatment of anxiety. What this means in doing an exposure exercise is for the client to gradually approach the fear in a gradual way. So first of all, we have to set up a fear hierarchy with the client. In that same case, same example of social anxiety, the fear hierarchy can be something like this, where different anxiety-provoking situations are assigned a level of fear. So in this case here, at the bottom is going to a small social gathering. And in this event, this situation only provokes a small amount of anxiety for this person. What would be slightly more anxiety-provoking? Perhaps would be to actively invite friends to a dinner. That would be anxiety in the region of 20 to 40 out of 100. And then moving on, something that's of moderate distress, moderate anxiety would be to speak with some of my unfamiliar classmates. And then at the top of the list, something that's really very anxious for that social anxiety person might be to speak in a group presentation. In graded exposure, the therapist guide the clients to confront the fear events, the fear situation, from the less anxious to the more anxious gradually. So we work with the easier tasks, and then when we have some success, we go up the hierarchy and work on gradually more challenging situations. It's like doing a lot of behavioral experiments, but keep doing it, keep going at it, in order to learn that he could cope well with the anxiety feeling. He does not need to avoid, he doesn't need the safety behaviors. But then it's a gradual exercise. It's not what we call flooding. Flooding would be to begin confronting the fear with the top of the hierarchy, confronting the event that gave this person the greatest distress. So it's not flooding, but gradual. Doing exposure exercise can be very challenging for clients because we are asking them to approach the very thing that they strive to avoid. So preparing the client with a sound rationale for doing the exposure can be helpful. The way I try usually to prepare or to explain clients why they need to engage in exposure exercise is by drawing a diagram, a graph. So in this graph, along the y-axis will be anxiety. So the higher up on the axis, the more anxiety, the stronger the anxiety for the client. Along the along the x-axis is time. As time passes. So for that person with a fear, with the anxiety of public speaking, what happens when he has to confront the situation of doing public speaking? What happens is that anxiety shoots up. He's so afraid of doing the public speaking. So whenever he has to do the public speaking, the anxiety feeling shoots up to a very high level. And then what happens? What happens is that he engages in avoidant coping, avoidant behavior. He escape, he leave the oral presentation to his classmates. So he doesn't need to do it himself. Now, when he does that, when he avoids the public speaking, what happens next? The anxiety goes down very quickly, because he was successful in avoiding the public speaking event. But then, of course, there may be the next time he has to engage in public speaking, the next time he engages in a group project, again, he's confronted with the need to do that oral presentation. So next time what happens is that when he is required to do public speaking, the anxiety go back up. And then again, as usual, he engages in that same avoidance, coping. So the anxiety go down and so on. How the public speaking, how the anxiety, social anxiety has been affecting him all his life. Now in exposure exercise, what we do is not to avoid, but to approach the fear, to engage in public speaking. And when we do that, what happens to our anxiety? The anxiety would go up initially because he really was so afraid to do the oral speaking. When he cannot avoid, he has to stand up in front of the audience and look the audience in the eye, he would get even more anxious, and up to a point where it cannot get any worse. The anxiety keep affecting him for some time. It's very scary during that initial period of doing the presentation. But then, of course, the rationale of doing the exposure is not for him to experience this anxiety in such an intense way, but to gradually experience that the anxiety would come back down, as he realized, oh, it's not actually so bad. The audience did not criticize me. They even, they even encouraged me by clapping. It seems rather okay, like anyone else doing an oral presentation. So when the client accumulates that new experience, the anxiety will go down and stabilize in the long run. So here, visually, the client can see very clearly the idea of doing exposure is not the initial, it's not just for suffering, for the sake of suffering, but the initial distress, the initial suffering would bring about some long-term gain. So really, it is the case of getting worse before getting better. Technically, this is what we call systematic desensitization for anxiety patients. So hopefully with this explanation visually and going through with the clients, this is in fact what is happening to your anxiety level. This is what happens when you avoid. This is what happens when you do not avoid. Having explained this slowly and carefully in a way that is understandable for the client, hopefully he will feel much more, determined to go through with the difficult behavioral experiments and exposures. So, all these behavioral work we do in therapy, in CBT, reflects that CBT is not really just talking therapy, but a form of doing therapy. There's a lot of doing and acting in the course of CBT. It's about connecting the head, what we think cognitively, and how we feel in the heart. More scientifically, we think about the workings of the brain, doing both the cognitive work and the behavioral work really is about integrating the thinking part of the brain and the emotional part of the brain and the sensory part of the brain. We need to make them work together rather than working solely on the thinking part, on the prefrontal cortex, where we evaluate our cognition. Because that's not enough. We also have to drive forward the other parts of the brain in order to make meaningful change. There's a variety of behavioral interventions. I've only talked about behavioral experiment, and one of it is derivatives in exposure. But there are also other behavioral interventions in CBT. For example, relaxation training, especially helpful for people with stress and anxiety-based difficulties. The therapist could teach the clients to engage in certain activities to help them relax, to deactivate the body's stress. Or another form of behavioral intervention is called behavioral activation. So in this form of intervention, we help the client identify their past interests and to kind of really do more in their daily lives. This kind of intervention is especially helpful for people with depression or withdrawal behavior, because when people become depressed, then what they do is to withdraw. They stay in bed, they stay at home, they tend to go out less, see their friends less. But we know from a lot of studies that merely helping the client to do more in his daily life can be very helpful in uplifting his mood. So this is not just behavioral experiments, but a whole range of different behavioral interventions we do in CBT. But essentially, what we strive to do using the cognitive and the behavioral interventions is to help the clients to build a different life story. We began with this case conceptualization, this old story of the problems that has been affecting the client, with the events, during the oral presentation and the cognition and the feeling and the behavior. What we do during the cognitive and behavioral interventions is to help the clients to formulate new ways of thinking, new ways, new feelings, because of the alternative cognition, of the new cognition. And with that new feeling would bring about a new behavior and a better outcome in the end. So the same goes for the other example we used earlier in the lecture of the person who reacted negatively to scoring poorly in the exam. So in cognitive work, we use a cognitive restructuring to establish that new cognition, and that would lead to less negative feelings and a more active way of behaving, of dealing or problem solving this situation, in the end with a different outcome. So finally, we'll run through quickly some of the principles in doing CBT. 10 principles that we will quickly run through. So first of all, CBT is based on an individual and evolving conceptualization of the client's problems in cognitive terms. So therapy is based on the cognitive model that we talked about in the early part of today's lecture. The conceptualization is the therapy anchor. Whenever we get lost during therapy, whenever we are not sure how to move forward, what intervention we should do, we go back to the initial conceptualization, and then we go from there. And also, this conceptualization can be updated, can evolve the more we know about the client. CBT requires a sound therapeutic alliance. So all the basic counseling skills, such as accurate empathy and positive regard, all these skills apply for CBT. Without a solid therapeutic relationship, then it's just unlikely that the client would benefit from the cognitive and the behavioral interventions we've been talking about. Another way to think about this is to simply treat the client in the way that you would like to be treated if you were a client in therapy. So building that strong, healthy, and respectable relationship is very important in CBT. It emphasizes collaboration and active participation. It's about making decisions together with the client, not imposing the therapist's ideas on the client, not saying to the client, so, I think this is your cognition and this is the way that you need to change the cognition to this new way of thinking. But it's a guiding process. We need to have the client make a lot of the decisions and come up with a lot of the answers during therapy. And also, as we mentioned, doing homework is an important part of CBT. So it does require the clients to be motivated to work on homework in order for CBT to be effective. It is goal-oriented and problem-focused. So in the early part of the therapy process, we establish with the client what to work on and then focus on them so that we don't, during the therapy process, we don't drift to different topics every time. We focus on dealing with that problem session by session until that problem gets solved, and then maybe we will work on the next problem. CBT initially emphasized on the present. So it means that in CBT, usually we begin by focusing what's been affecting the clients in present days, in the present context, rather than focusing the therapy session to talk about things that happened in the remote past. For example, his childhood upbringing in the family. But there are exceptions. CBT does not exclude working on the client's past. It really depends on the therapy situation. For example, for clients with long-term personality difficulties, then CBT would put much more focus on finding out about the client's experience in his developmental upbringing and how events from his childhood form the negative core beliefs, the schema that has been affecting the clients and forming his personality. CBT is educative, so it aims to teach the patients to be his own therapist and emphasizes relapse prevention. Essentially, this therapy is about building self-reliance so that the client in the long run does not need to rely on the therapist, but can rely on himself. And in relapse prevention, even though through the course of therapy, the client has gotten better, is no longer depressed or no longer very anxious, we do prepare them for when things get worse again. It's about like building a house. We have to prepare the roof in sunny days in order to prepare for the rainy days, the stormy days that may come in the future. CBT aims to be time limited. So depending on the clinical problem, the time could vary, but we aim to use as little sessions as possible in dealing with problems. Therapy should not go on for many years because that has the danger of having the client rely on the therapist rather than relying on themselves. But of course, there are also exceptions. For example, for severe mental disorders like schizophrenia or bipolar disorder, then CBT does allow for more sessions in order to help with the difficulties. Sessions are structured. That means CBT for each session, there is an introductory part, there's a middle part, and there's a final part. We have this structure here in order to be more efficient in therapy. We use that 50 minutes or 1 hour therapy session to do as much as possible. And if we have a standard structure where the client, every time they go to the therapy room, know what to expect, know the structure that they will go through during the therapy session, then we can work more efficiently. CBT teaches patients to identify, evaluate, and respond to their dysfunctional thoughts and beliefs. Now, this principle is essentially what we have been talking about in today's lecture. So hopefully you would already at this moment have a very good idea on what this principle means. Lastly, but not least, CBT uses a variety of techniques to change thinking, mood, and behavior. The therapy techniques can be varied. As I said, it's not just about the cognitive restructuring and the behavioral experiments or the exposure that I've selected to focus on in today's lecture. But there are a lot more techniques specific to different disorders. But all these different techniques adhere to the same cognitive model, the same theoretical basis of CBT. Because CBT is a school of therapy, there are extensions to it. There are other therapies falling under this school. Some of them, mindfulness-based cognitive therapy, dialectical behavioral therapy, and so on. So if you are interested in learning more about CBT, you have to recognize there's a lot more to CBT than what I have shared with you today in this very limited time and just a very brief and basic introduction. If you are interested in CBT more fully, then there's a lot more for you to read into, to learn about. It's really why we call CBT as a school of therapy instead of just a standalone therapy on itself. And on this note, I think this is all I have prepared for the lecture today. Thank you so much for your time. I know it is not the best time on a Friday afternoon for a lecture, but hopefully I have not, confused you too much with the information that I have shared with you today. We are approaching 6 o'clock, the end of the lecture, but if you have any questions regarding what I've been talking about today, feel free to drop any questions now to the chat room. I think I have these questions in front of me popping up right now. So first of all, thank you so much for the compliments. I will read your questions so that everybody is, I'm sure everybody knows which question that I am addressing. So a question for behavioral experiments. If the results, unfortunately, were the same as the prediction, then what do we do in that case? Oh, this is a great question, and let me go back to that slide. So it does happen. Sometimes it is the case that the outcome of the behavioral experiment in fact matches the prediction, the catastrophic expectation that we initially hope to help the client change. What should we do here in this case? What we should do is to, first of all, in running a behavioral experiment, we should not expect a particular outcome. We should leave our options open. For example, in this case, the catastrophic expectation is that the audience would come forward and criticize me. And in fact, this is what happened when the client, tried to give that oral presentation. But at the end, someone came forward and told the clients that your presentation was so bad, so poor, totally wasted my time. You should have prepared better for your presentation. Now, what should we do in therapy if that's the case, if that's what the client reports to us? We should then, first of all, validate the distress, because it is indeed a very distressing situation. It's very upsetting. You may worsen that anxiety feeling. So first of all, we have to validate it. It's such a upsetting experience. And having done that, next goal in therapy would be skill building the skills in oral presentation. Because we know from the experiments, the data that we have gathered is that, in fact, the client is not good at doing oral presentations. So what to do? What would be the solution? where the solution is to build public speaking skills, perhaps in the form of doing role plays in therapy, so that the client would get gradually more skillful and proficient in doing public speaking. So, so this is what I would suggest, building the skills if in fact the skill has been lacking. So hopefully I have addressed this question. Next question, how could CBT be used for people with psychotic disorders? Given that psychotic disorders are characterized as thought disorders, which makes their delusional thinking difficult to be disputed. Indeed, it may be said that the people with delusional thinking, with paranoia, their negative cognition can be rather fixed, much more rigid than people with more common mental health disorders such as depression and anxiety. But there are, in recent years, a lot of research studies showing the effectiveness in CBT for psychosis, CBT for, working on auditory hallucinations and certain delusions. I think the basic principles of using CBT on this kind of problem is the same as what I have been sharing with you in the lecture, the same with working with any other disorders. But we have to be a little bit more careful and open-minded and be very careful not to challenge the patient's delusion too directly. The process has to be much more gradual. It has to be much more tentative. Do not assume the position that the therapist knows that the delusion is wrong. Because by directly challenging the patient, the client, it is very likely to get backfired. The trust will be broken, the client will get disengaged from the cognitive process. So I would suggest to move along the process more carefully and slowly. But it is something that is, the data show us is workable. It is what I do in my daily work in the psychiatric hospital. In fact, just this week, I saw a new patient, an inpatient with diagnosis of schizophrenia, having paranoid ideation that other people, they are scheming to prosecute him. For these patients, we do also try to use CBT to help them. And sometimes we do see the benefits of this form of therapy. So, yes, I think CBT could be used for psychotic disorders. The next question. May I know if CBT is suitable for all clients? Are there any clients not responding well to CBT treatment? I think so. There are people who do not respond well with CBT. Out of the top of my head, I would say people who are not motivated to make efforts, not motivated to make change in their lives. Maybe in such a case, I will focus more on in my therapy sessions in doing motivational interviewing to work on the motivation before beginning a course of CBT. And also CBT is not the only form of psychotherapy that is evidence-based. Today, my topic is on CBT, but there are other forms of evidence-based therapies. For example, emotion-focused therapy, and so on. So it's a very difficult question in terms of what form of therapy work for what kind of clients? It's a very difficult question, and from the data, we are not very clear about the answer to this question. So sometimes in therapy, we have to work creatively and flexibly. Next question. I want to ask how CBT practically faces depressive realism, which when things are real, but bring negative emotions to clients. So for this question, I would like to go back to a slide here. So in CBT, we recognize that sometimes, things are very gloomy. The world can be a difficult place to live in. The reality could be tragic. So we recognize this is a part of our lives. We validate the distress. Sometimes we normalize the client's distress. And then we try to move forward by thinking how to think and how to act in a more helpful way, even in this difficult situation, in this tragic situation. For example, the young man who lost both his legs from a road traffic accident, despite losing both his legs, life goes on, and how should we deal with that? How do we move on? What are the stuff that we can do from now on? So it is about recognizing the reality, but also at the same time moving forward with life. So how do we face this depressive realism? We just recognize it, and we validate it. We don't shy away from it. That is how we should, deal with depressive realism. So I'm seeing no more questions popping up in the chat box, and we already passed the time of the lecture. So thank you again so much for being here. Your motivation for learning this therapy is really appreciated, and I hope that this lecture has helped you to form a decision on whether you would like to learn more or learn more about this therapy, or just to abandon it and to learn about different things instead. So thank you very much, and I hope you have a very good weekend.